Hello, very good evening to all of you, my dear friends. Myself, Dr. Darshan Bajaj, and wishing all of you a very happy Holi. And you can see, like, I haven't got rid of my colors, and I am glad to have them on my forehead. And today, we are going to have a very nice discussion on refeeding syndrome. So, this is a topic which is probably new to many of us, and but we have tried to put up a good show. And I have, four gems, four kohinoors with me, the four pillars of my this webinar. So I will introduce them one by one. So first and foremost, person from Modi family is also with us. So not to worry anything. So Dr. Mahavir Modi, sir. So he is a consultant pulmonologist from the Ruby Hall Clinic since last 22 years. He's a director of Modi Clinic. So, and he has got numerous, credentials to his name. He has a diploma in pediatric sleep medicine. He has got the Lokmat Dhanvantri Award, the Bharat Ratna Indira Gandhi Gold Medal also. And he has some fellowships to his name in IP from Italy under the guidance of Dr. Stefano Gasparani. So that's wonderful, Dr. Modi. So moving on, we have the lucky charm of a lady and Dr. Devi with her. So Devi, please let's give us blessings for this webinar. So right now, Dr. Devi is the HOD professor at SBIMS Raipur, and she is also director of Nivet Chest and Eye Care. So our areas of interest are in COPD, allergy, and sleep. And she has also got numerous fellowships and awards to her name. And she has more than 30 international and national publications. So two chapters in textbooks also. So Dr. Devi, welcome. And now we have Dr. Bhima Shankar. So he's a very renowned pulmonologist from Kakinada, and he is serving people at Kakinada, and he is the professor at KIMS uh, Am- Amalapuram, if I am right. And then Dr. Dwai is with us from Siliguri. And Dr. Dwai, you can see, he's a young, dynamic, cute pulmonologist. And so he's having a special interest in COPD and obstructive disease. And he is also doing IP procedures also. So Dr. Dwai, welcome to this brainstorming webinar. And we are not still out of the holy hangover. And today we have a exciting match, the semi-finals, India versus England. So we will try to finish up in time so that we can see the climax of the match and hope India wins and these are the finals. So uh, the organizers, I want to thank them, Dr. Krishna sir, Dr. Atri, and Dr. Dosi, and all the team from the CCI. Like they have thought of me as the moderator and out of the box person. So, uh, so can we have the presentation? Can we go ahead with the presentation now? So I am sharing my slides. So, so my warm greetings to everyone. Myself, Dr. Darshan Bajaj, and I am the moderator of today's session. And presently, I am working in the capacity of a professor at Department of Respiratory Medicine at King George's Medical University, Lucknow. So this is I, me, and myself. And before that, I would like to wish you Holi. And Holi was around the corner, and we were also celebrating the Holi festival as well as we were trying to put up a good show for all of you. So we hope that we will not disappoint you today. These are my esteemed panelists for today's out of the box topic. And somehow I am the out of box moderator today. Thank you, Krishna sir, and Dr. Atri, Dr. Ravi Doshi, and the technical team and CCI. My four gems, though, they are they, they don't need any introduction. They are my strength of pillars. So Dr. Mahavir Modi from Pune, Dr. Devi Jyoti Daksh from Raipur, Dr. Bhima Shankar from Kakinada, and Dr. Doi Payan Ghosh from Siliguri. So I will like to start this PPT with a quote that you should not bite the hand that feeds you, but maybe you should if it prevents you from feeding yourselves. So a little bit of historical backgrounds, make the narrative interesting. So this refeeding syndrome was first described after World War II. And was first coined by 1981 by Winseer and Crumdier. Difficult names to pronounce, but anyhow. And the star prisoners, they develop cardiac failure and neurological symptoms after refeeding. And it was seen that nutritional rehabilitation itself can be dangerous. So this is a little bit of historical aspect of this. And refeeding syndrome is a common but under-recognized situation. It can lead to life-threatening complications, entirely preventable with awareness. And it is seen across various disciplines like medicine, ICU, surgery, psychiatry, and all others. So that is why this topic is relevant. So our learning objectives for today's, this refeeding syndrome, we have to define refeeding syndrome and its core pathophysiology and management. We have to identify the pulmonary and critical care manifestations of the syndrome. We have to recognize the high-risk respiratory patients, including COPD and the ICU patients. We have to understand the impact of this syndrome on respiratory muscle function and the ventilator weaning. And what should be the practical prevention and management studies in these kind of patients. So defining this syndrome, it is a potentially fatal condition and due to fluid and electrolyte shifts that occur when nutrition is reintroduced after prolonged starvation or severe malnutrition. And hallmark of this syndrome is the hypophosphatemia following the refeeding. So when does it occur? So it usually occurs within 24 to 72 hours of refeeding. It can occur with oral feeding, the enteral fluid nutrition or the parenteral nutrition. And the risk persists somewhere for around 5 to 7 days. So what happens to the normal metabolism during starvation? So there is, decrease in insulin secretion, and there is an increase in glucagon and catecholamines. So energy in that time is derived from fat and protein. And what happens is that intracellular phosphate, potassium, and magnesiums, they go down. But serum levels may appear normal. So in that metabolic shift during refeeding, there is carbohydrate intake which leads to increased insulin secretion. And it further leads to cellular uptake of glucose, cellular shift of the phosphate, potassium, and the magnesium. Because of sudden increase in the cellular demand of these things, the serum electrolyte levels, they go down, they fall. So coming to the pathophysiology of refeeding syndrome. So there is, first there is starvation. Then, of course, when we reintroduce the food, there is refeeding, which leads to insulin surge. Then it leads to electrolyte shift. And finally, culminates into organ dysfunction. So the starvation state leads to decrease in electrolyte stores in the cells. The refeeding, there's a carbohydrate, which leads to increase in glucose, insulin surge. There's a cellular uptake of potassium, phosphate, and magnesium. So there is a decrease in the serum levels of all of these electrolytes. And because of these electrolyte shift into cells, they all go down, leading to the organ dysfunction. Key results, hypophosphatemia, which leads to arrhythmias, respiratory failure, neurologic complications. So the key electrolyte disturbances are of phosphate, potassium, magnesium, and that very important, this thiamine, vitamin B1. So in phosphate, the clinical impact is the respiratory failure and arrhythmias. For potassium, there is, weakness, arrhythmias. Magnesium leads to QT prolongation, seizures. And thiamine is a very important, aspect and leading to the encephalopathy and the heart failure. Now, what are the population at risk? So the NICE and SPEN guidelines, they have, given this beautiful, paper on the recommendations for the refeeding syndrome. So there are some population at risk, and we will come to those in the forthcoming panel discussion. So this is kind of a clinical pearl for all of you, that normal baseline electrolytes that do not rule out refeeding syndrome. Electrolytes fall after feeding starts. So please remember. So early clinical features are fatigue, weakness, muscle pain, peripheral edema, tachycardia, mild confusion can be there. and it can lead to severe clinical features like cardiac arrhythmias, acute heart failure, respiratory failure, seizures, coma, or even sudden death. So coming to the lab findings, the most common is hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, hyperglycemia, fluid retention. So coming to diagnosis. So you have to make a clinical diagnosis of this kind of presentation, and it is based on history of starvation or malnutrition, then initiation of reintroducing the food, and when you see the new electrolyte abnormalities in such kind of patients. So there is no single diagnostic test of these kind of manifestation. So what is our strategy for prevention? The core principles. So you have to identify the risk before feeding. You have to start slow nutrition. You have to collect electrolytes proactively. You have to supplement thiamine routinely. And of course, you have to closely monitor these kind of patients. So this is a clinical part 2 for all of you. Refeeding syndrome is not caused by feeding. It is caused by feeding too fast. Okay. So this is a clinical case scenario. There is a 65-year-old man with, history of chronic alcoholism. There was no oral intake for 12 days. He was started on the nasogastric feeding at full calories. And after, around 48 hours, he presents with dyspnea, confusion, and the ECG was, suggestive of ventricular ectopics. So case one, it is a high-risk patients, and there was rapid refeeding. So likely there was hypophosphatemia and hypokalemia. So it is a case of classic refeeding syndrome. So coming, so there is a young female with anorexia nervosa. That gentleman was old. She is a young female with anorexia nervosa. So this is a high risk category. So BMI is only 14 kg per meter square. And she was started on oral diet. And on day 3, she develops muscle weakness, low phosphate, and rising edema. So learning points for the case 2, there is high risk despite oral feeding. So as I told you previously, it can occur due to the oral feeding or the enteral nutrition or the parenteral nutrition. So this case was seen outside the ICU. So it can also occur outside ICU. So oral feeding can be equally dangerous. So we have to monitor just like the other patients. So what are the hospital and ICU implications? So it is seen frequently in ICU patients we are stepping down those patients. So when we step down any ICU patient, then there is tendency to like feed that patient after a period of malnutrition or starvation. So there are prolonged NPO states, patients with post-sepsis recovery. Sorry. So you have to develop some protocols of refeeding these patients. So this is a brief recap. You have to identify the high-risk patients. You have to give thiamine before or with feeding. You have to start low-calorie feeding. You have to monitor electrolytes. You have to replace them. You have to gradually increase in nutrition and monitor those patients. So we will discuss this further in the panel discussion. Now coming to the actual topic of the day, refeeding syndromes with the pulmonology perspective. So you see, our respiratory system is highly vulnerable to electrolyte shifts. Hypophosphatemia leads to decrease in the ATP. It leads to further in the decrease in the diaphragmatic contractility. There is an increased CO2 production versus ventilatory load, often misdiagnosed as exacerbation of COPD or weaning failure or ICU-acquired weakness. So there is an insulin surge. There is an intercellular set of phosphate, potassium, and magnesium. The phosphate depletion leads to reduced 2,3 DPG. There's an impaired oxygen delivery, which results into a respiratory muscle fatigue and the failure. So this is the pathophysiology of the in the refeeding syndrome of pulmonary disease. So what is hypophosphatemia relation with the respiratory failure? This is the key mechanism. So there is decrease in the ATP synthesis. So the pulmonary consequences, diaphragmatic weakness is there, decreased 2,3 DPG is there, so tissue hypoxia is a manifestation of that. some muscle proteolysis, there is a poor cough and secretion clearance, there is an increased CO2 production leading to the respiratory acidosis. So these are the key mechanisms of the depletion of various things. So clinical pearl number 3, in malnourished patients, unexplained respiratory failure after feeding leads to refeeding syndrome until proven otherwise. Now, a very important disease of pulmonology, of course, COPD. And this refeeding syndrome in those patients is a kind of hidden threat. So these patients, we know that they are frequently malnourished, they have low muscle mass, they are having chronic hypoxia. So this syndrome may precipitate acute respiratory decompensation in these patients. There is a difficult ventilator weaning. So in patients who are having COPD, there is malnutrition, there is low respiratory muscle reserve, the refeeding leads to increased CO2 production, there are electrolyte shifts, there is further diaphragmatic fatigue, and we have to deal with the hypercapnic respiratory failure. So coming to clinical case number 3. So this is a 68-year-old male. He has a case of severe COPD. The BMI is 17 kg per meter square. He has a history of recent hospitalization. So this patient was started on full calorie enteral feeding. So it presents with rising PaCO2, diaphragmatic fatigue, and low serum phosphate. So our diagnosis is the refeeding syndrome. So as we see these cases, we are seeing in our day-to-day practice, but we are not aware of the syndrome, but now we are a bit more wiser in the syndrome. So this is the advantage of conducting these kind of out-of-the-box topics. So we need to learn and relearn all these things. So refeeding syndrome in the ICU, the respiratory implications. So ICU patients, they often have acute catabolic stress. They are having pre-existing malnutrition. So even only if you are giving dextrose to these patients, it can lead to the precipitation of the refeeding syndrome. And respiratory failure becomes a major cause of mortality in such kind of patients. Now, sometimes patients, we are not able to, wean off from the ventilator. So in that also refeeding syndrome has a role to play. And we are like, we are not knowing that. And so after we are making a diagnosis of refeeding syndrome, we have to address it accordingly. And so it will help us in the proper weaning of this kind of patients. So hypophosphatemia leads to weaning failure. And further, there is an increased ICU stay, higher mortality. So it is often, mislabeled as ICU-acquired weakness with the persistent lung disease. But actually, it is a case of refeeding syndrome. So clinical pearl, always check phosphate in unexplained weaning failure. So next time you see a patient where it is difficult to wean him or her, then please check the phosphate levels. So coming to the last slide of my presentation for a context setting. So parting messages, still many things are unanswered, and we will cover all those things in the panel discussion. So refeeding syndrome is a potentially fatal complication, but fortunately it is predictable and preventable. So that is a good part. Hypophosphatemia is a hallmark abnormality, but potassium, magnesium, thiamine also, and fluid shifts, they contribute significantly to the organ dysfunction. Normal baseline electrolyte do not rule out refeeding syndrome. Respiratory system involvement is common and often under-recognized. Pulmonary and ICU patients, especially those with COPD, chronic lung disease, prolonged ventilation or cachexia, they are at particularly high risk. Unexplained respiratory deterioration or weaning failure after feeding should prompt evaluation for the refeeding syndrome, especially the serum phosphate. So prevention becomes the most effective strategy. So these are the some references. You can take these from me afterwards. So thank you. Keep feeding your brains. Now we will go for the panel discussion. Thank you. So now after this PPT, many questions are there in the minds of all of those who are logged in this webinar. So we have formulated some questions for our panelists, and we will start with the lady luck of our webinar. So, Dr. Devi, I would like to ask you, how will you define starvation?
Thank you for starting with me, and I want to thank CCI for this opportunity. So, starvation is a severe medical condition where there is extreme deficiency of the caloric intake, and thus the body exhausts the storage of glycogen, fat, and also it uses the structural protein. We can say that it is the most extreme form of acute malnutrition, which can cause even organ damage and even death.
So excellent, Dr. Devi. Thank you for that brilliant answer. So now, the person coming from the Prime Minister family, Dr. Mahavir Modi sir. So, sir, can you just let us know what is the basic difference between starvation and fasting?
Yeah. So again, thank you very much, Darshan. Your presentation was really nice, and congratulations. And I mean, thank you, Dr. Krishna and the team, because this topic was, although practicing medicine for last 22 years, this is something which I had never read. So I have a confession to make about this.
All of us are sailing in the same boat.
Yeah, it's I mean such a huge topic, and it's such an important topic because we keep on feeding our patients day in and out, and without thinking that what can be the complications of this. So thank you very much, CCI, for this wonderful webinar. So starvation and fasting again. I think starvation. It's fasting is something what we all must have done for one day, maximum on 2 days. So voluntarily on the day of Mahashivratri, on the day of Gokul Ashtami, and sometimes Devi Jyoti must have done it for what do you call it as
Karwa Chauth.
Karwa Chauth. So that is all fasting. So this is all voluntary. And I think starvation is something what, my daughter is now studying in final MBBS. So she has 13 subjects to clear. And then she goes into that zone of, not eating, and it becomes like a pathological. So it is involuntary. She just not eating. And sometimes it can be, it's like a prolonged fasting. It may be involuntary. It may be sometimes even pathological. It can be a manifestation of some disease process. So, definitely, it is just an extension of fasting, but the complications of starvations are definitely much, much. In fact, fasting has some effects. If you see that nowadays, everybody says that even in Ayurveda, as well as for this telomere shortening or these kind of things. So to prevent those kind of things, and even for age reversal, so there are definitely trials which say that if you're doing fasting, maybe sometimes even intermittent fasting, or maybe having a fast on one of the days of your week, so those kind of things, they definitely help to regenerate your body, just like uh, sometimes uh, a snake just shades the skin. So similarly, something similar to that can happen with fasting, but that doesn't happen with starvation, because starvation can have a lot of impact. There can be glucogenolysis, and plus after that, this all your fatty acids, all your amino acids, your muscles, they all will start having breakdown, and from there the body will start having synthesis for the glucose. So starvation is definitely something which is not physiological, it's a pathological process. Thank you.
Excellent, sir. Thank you, Modi sir, for all those religious, and analogies for that answer. And definitely, excess of everything is bad. So even excess of fasting is also bad. So coming to another basic question, Dr. Devai is the panelist for this. So, Dr. Devai, how will you define malnutrition?
Firstly, good evening and thank you, Darshan sir and both CCI team for having me over here. This is actually, as everyone is saying, this is a very new topic for all of us, and we all had to put some efforts to gain some knowledge on it. The refeeding syndrome term I had been hearing from my ICU colleagues, so and so forth, but I haven't thought of learning actually. So got to learn something. And malnutrition, as you asked me, sir, malnutrition is a very basic medical condition that is because of unbalanced nutrition. It's so it can encompass both undernutrition as well as overnutrition. So basically, we are having the nutrients, the calories, the proteins, and micronutrients in a very unbalanced form. So it encompasses both the sector, both the segment, both the spectrum. So In one line, it's a poor nutritional status, which is including deficiencies in the calorie, protein, and micronutrient, or the excess of it, leading to overweight, leading to obesity, and all of these are finally culminating into a metabolic derangement. So that is what malnutrition is.
So I would like to highlight that overnutrition is also malnutrition. Thank you for bringing out that point. So just an extension of this question to Dr. Bhima. Can you just let us know the types of malnutrition, Dr. Bhima?
Yeah. At the outset, I would like to thank the CCI for providing this opportunity. And Darshanji, you have provided a very good and very nice presentation on this topic. And most of my question has been covered by Dr. Dwaipan. So malnutrition, as we usually think, malnutrition means we think it as a lack of nutrition, right? But malnutrition is not just limited to lack of nutrition. It has been broadly classified into three different types. So first one is undernutrition, where the body does not receive the required amount of nutrients or energy. And it is again of various subtypes, like acute malnutrition, that is wasting, where because of sudden food shortage or acute infection leading to severe weight loss, that results in wasting. And second type is stunting, that is chronic limitation of food or long-term insufficient food intake that leads to improper growth, leading to imbalance in between or height to the age. So that is stunting. And the next one is underweight. So underweight can be both wasting or stunting. And to the other end, we have overnutrition. So here it is excess intake of calories or unwanted nutrients, leading to overweight, obesity, or various non-communicable diseases. In between these two is improper diet or dietary imbalances. So where our it can be excess or deficiency of either macronutrients or micronutrients. Say for example, deficiency of proteins lead to kwashiorkor, deficiency of carbohydrates lead to marasmus, or our iron deficiency, micronutrient deficiencies like iron deficiency leading to anemia, or vitamin A deficiency, vitamin D deficiency, or zinc deficiency, various other micronutrient deficiencies. So these all subtypes all comes under malnutrition. It's not just lack of food, right? So addressing this malnutrition needs a balanced diet and more attention towards quantity as well as quality of our nutrients. Thank you.
So thank you, Dr. Bhima. Your answer reminded me of the, like in our childhood, we used to read O.P. Ghai from pediatrics, and there was a flex sign, a golden color hair in the children. And I used to think why it happens, and that was due to the protein energy malnutrition.
Yes, yes.
So, thank you. So now coming to the hallmark of this refeeding syndrome, and that is hypophosphatemia. And so for this, for this, I will like to ask Dr. Mahavir sir that why phosphate is critical for functions of human body.
Yeah, so thank you, Darshan, for the question. So phosphate is basically, we all know that ATP is our main unit of any of the cell. Okay, so ATP is your adenosine triphosphate. So phosphate is basically required for the production of this ATP, and ATP is something where all our body will function basically on the cell unit. That is our ATP. Just like your mobile also will require a battery to be charged. So similarly, for our body to get charged, I think ATP is our main charging agent for all of our cells. Each and every cell will have ATP. The second most common thing what phosphate reminds us is basically about, because almost 85% of the body's calcium, body's phosphate is basically stored as calcium phosphate, and it's in the bones and in the teeth. So it is required definitely for the functioning of the muscles. It is required for the functioning of the nerves. And we have seen that the patient, those who have low phosphate levels, they may have even the disturbances in the cardiac impulses as well as in the for the functioning of the nerves. So it is required for the functioning of the cardiac system, as well as it is required for the functioning of the nervous system. Even our cell membrane, so cell membrane structure, even the DNA structure, the RNA structure, so they all have phosphate as the main component. Even in patients, like you were discussing in your slides about the critically ill patients, and in these patients, for the maintenance of the acid-base balance, So even in the acid-base balance, when we calculate the anion gap, so we know that the phosphate also have a critical role in maintaining the acid-base balance. So all these things are definitely required for the phosphate has an important role in our body. One more very important thing where the refeeding syndrome comes in place is about the enzyme activation. So phosphate is again required for production of certain kind of enzymes, the phosphorylation in Krebs cycle. So all these are basically important functions about phosphate. So it is required for the energy, for the bones, for the muscles, for the heart, for the cell membrane, for the genetic material about your DNA, RNA, as well as maintaining the pH of the body. So I think it's a quite a vital system, quite a vital electrolyte which we often miss in our clinical practice. And we give a lot of importance to sodium, potassium, maybe sometimes calcium, writing extra calcium to all our patients, but we don't give that much of importance to the phosphate.
So yes, Dr. Mahavir sir, you are absolutely right. You are hardly giving any attention to phosphate. And now, of course, with this new entity, which is under-recognized, basically it is a no very well-known entity, but we were not looking at this in this perspective. So phosphate is the most consistent marker of refeeding syndrome. And so please, it's my message to all those who are logged in that please now pay attention to phosphate, and all those weird presentations in the ICUs or your patient, just look the phosphate levels or just introduce the refeeding in a way which we are going to discuss in our further questions. So just I also want to apprise the audience that some may be thinking that what are the rich sources of phosphates, because we are talking, so in a layman term, what should we advise like to give phosphates? So of course the artificial or injections, they are another thing, but like seafoods or the dairy products or the meat or the salmon and seeds, so these all are rich sources of phosphate. So you can advise your patients, attendants to give these things for maintaining those levels of phosphate. So these are layman things for. So that was the point I want to just bring in. So just a second. Moving on, a very important aspect, and Dr. Devi, can you just let us know what are the high-risk populations as per the NICE and SPIN guidelines?
Yes, sir. Thank you. Yeah. So NICE guideline gives a more practical and simpler recommendation as in who are the high-risk population for refeeding syndrome. SPIN is the most recent one. However, there are slight differences, but the crux is same. So any one of the following: BMI of less than 16 kg per meter square, unwanted weight loss of more than 15% of the body weight in last 3 to 6 months. As per SPIN, it is 7 to 10%. Little or no intake for more than 10 days. As per SPIN, it is more than 7 days. And decrease in potassium, magnesium, and phosphate levels before the refeeding starts. So all these keep the patient at high risk. However, also chronic use of alcohol, chronic use of drugs like chemotherapy or anorexia nervosa, all these things also keep the patients at high risk.
And some chronic disease like cancer or any chronic disease, these are also, patients of high risk. Like I told you about COPD and a patient of anorexia nervosa, elderly age group. So these all are, they form the high risk populations. So now, Dr. Devai, we were talking about electrolytes plus thiamine. So what is the role of thiamine in optimizing body physiology?
That's a very nice question, sir. Actually, Dr. Modi was highlighting about the phosphate. So I just wanted to add one point that since we are highlighting phosphate, we should not be thinking even a bit less about thiamine. Thiamine is an extremely important thing in our body. As I was going through the literature, of course, from our physiology days, we have read a certain role of thiamine. I'll just try to summarize a few of them because it's no end. Thiamine plays a very pivotal role in the most important Krebs cycle of our body, which is important in all the organs functioning, creating almost 60 to 70% of the body's ATP. protein synthesis. Thiamine is also a cofactor coenzyme in the pyruvate pentose phosphate, which produces the nucleotide, the DNA, RNA, and also for fatty acid synthesis. Then again, thiamine is a regulator of the reactive oxygen sequences and also the reactive oxygen species, reactive nitrogen species. So naturally, it has a role to play as an antioxidant. Thiamine is also required for differentiation of T lymphocytes. So it has a role to play in body's immunity. It is also an activator of the macrophage activity in phagocytosis. So again, it has a role to play in body's immunity. Then again, few recent literature I was just going through last night only. Thiamine is also important, and not as a cofactor, not as a coenzyme, but as a constituent structure in the exoplasmic and synaptoplasmic membranes of the central nervous system. So it's a very acute thing where the central nervous system's functioning will depend on. Also, it has an ACH inhibitor activity, because of which it's again important in the brain's functioning, the brain's all of the impairment of the brain. Also, thiamine is a regulator of serotonin, GABA related all the pathways, and glutamine related pathways, as well as aspartate related pathways. So again, for the good functioning of the central nervous system, thiamine is a pivotal thing. So I just could summarize a few of them, but there's no end to it. So thiamine is extremely important, and as we will proceed with the next slides, I think we will mention this point that thiamine first, then everything else during the treatment of refeeding syndrome. That's it, sir.
Brilliant, brilliant. Thiamine is no less than any other like electrolyte or anything. So I remember my first year days, and I was MD GR1 and way back 20 years back. So my GR2 used to give thiamine in some critically ill patients. And I was just, was mechanical. He used to order me to give thiamine. It was available like Trinuresol H. I still remember that, ampule was coming. And so after so many years now, I am, because, very many years have lost, and now thiamine has come. Like, we of course gave multivitamins to our patients, but thiamine, the actual role, comes in, patients in which we have to like address encephalopathy, or we have to like prevent heart failure in those patients. So thiamine is really very important. So it is vitamin B1, of course. So now we were talking about the refeeding syndrome. We have talked in the presentation of pathophysiology. We have what is refeeding syndrome. We have defined it. We have seen the high-risk populations. We have seen what is going down. Now, how to manage it? So it comes to brings me to a very important question. So, Dr. Bhima, I think you will be the best person to answer this question. What should be the safe feeding strategy in such kind of patients to prevent refeeding syndrome?
Yeah, I think this is the most important part of our discussion today. There is no specific recommendation or strict guideline on how to manage these cases. Or
emphasis on what points you want to like, so that the audience gets our message correctly.
Yeah. So the most important point in treatment of this such cases is, first thing is risk stratification. We should be assessing whether he is at risk of refeeding or not, and if he is at risk, whether he is of high risk or low risk. So the next point is assessment of his electrolyte status. We must assess the potassium levels, phosphorus levels, magnesium, sodium, and apart from that, his fluid balance, fluid balance levels, and his renal function, his weight. So these are a must before starting the electrolyte, before starting the calorie supplementation. And after that, as our earlier speaker said, the thiamine supplementation. Irrespective of the risk status, thiamine should be supplemented for everyone. If the patient is having low risk, supplement 100 to 200 micrograms per day for 3 days. If he is at high risk, supplement for 5 to 7 days. So thiamine supplementation is a must. And next comes the calorie supplementation. Calorie supplementation should be taken only after complete correction of the electrolytes, especially phosphorus and potassium. So as you mentioned even in your presentation, we should not be overwhelmed with a normal electrolyte level in serum. Okay, if the serum potassium levels or serum phosphorus levels are normal at the start of the treatment, if we should not be carried away that he is not having a risk of refeeding syndrome. So after correction of electrolytes, then we should go for calorie supplementation. So the funda of calorie supplementation in especially high risk patients is start low and go slow. So we should be having a conservative caloric strategy, supplementation strategy. So as per ASPEN 2020, we should start with, especially in high risk people, we should start with 10 to 15 kilocalories per day or 100 to 150 grams of dextrose per day. Okay. And assess his vitals every 4th hourly, assess his electrolytes every 12th hourly. If he is fine, and after 1 to 2 days, try to escalate the calorie supplementation by 25 to 33%. Try to maintain the target for 50% by 4th to 5th day and 70 to 80% by 5th to 7th day, right? So after 7th day, if there is no refeeding syndrome, because most of the risk of refeeding syndrome will be between the 5 to 7 days after initiating the calorie supplementation. So if he is stable after 7th day, then you can completely transfer to his complete calorie supplementation, right? So another important thing in this treatment strategy is monitoring. So monitor his vitals every 4th hourly for the first 24 hours, monitor daily, monitor his electrolyte levels, monitor his renal function, and monitor his cardio respiratory function, right? So
excellent.
this is the main funda of refeeding strategy.
So I will just like to take a few points from your answer and summarizing for the audience. So you have to start, calorie added 10 calorie per kg for the patient. And you have to build in around in period of 1 week, and you have to avoid excessive carbohydrate loading. So, and of course, we will further like delve into electrolyte management. So that will be our next part. So Dr. Devai, coming to you now. So what is the strategy followed for electrolyte management of such patients?
Yeah. Sir, for electrolyte management, we have to focus on mostly on 3 electrolytes. Phosphate always first, then magnesium, potassium, and all those things. So according to the latest guideline, I just tried to summarize the points because there had been many discrepancies in between the consensus. So for phosphate, they are saying that we should not be even waiting for the symptoms to occur. If we are giving and going slow with the carbohydrate, whenever we find that the phosphate level is below 2, not even 1, below 2, we will start with an adult phosphate solution at the rate of 0.16 to 0.32 millimole per kg. So basically we know that the potassium will also be coming low in these cases. So it's better to choose a potassium phosphate over the sodium phosphate. So we have those ampoule of POTPHOS which has 10 millimole of phosphate. So we choose 2 ampoules of such. We mix it with 100 ml and we give it over around 2 to 3 hours. We also recheck the phosphate every 4 to 6 hours after that. Our target will be above 2.5. And now the basic phosphate level, if it is less than 1, we will start the phosphate adulteration with a that is 0.32 to 0.64 millimole per liter. So that's about phosphate. And of course, we will have to monitor, as Dr. Dania was also saying, that we have to keep on monitoring symptoms coming in case of deficiency, and also if our patient is responding to the phosphate recommendations or not. Apart from that, then comes the magnesium and potassium. Potassium, as the standard protocol we do follow, that is 10 to 20 milliequivalent per hour. That's the standard protocol, obviously IV infusion. And with magnesium, our target will be around 2.5 or so. So initially, of course, then we can probably increase. And the magnesium, 1 to 2 gram magnesium sulfate, that is also the standard protocol in 100 ml NS or 5% dextrose, and we give it over around 2 to 3 hours. So that's about phosphate, potassium, and magnesium. Then monitoring is also a part of the management. We monitor around 4 to 6 hours initially. If the patient is not having aggravated symptoms, we can monitor probably 12 hourly for the next 2 to 3 days. And after 7 days of electrolyte management, then we can probably see the monitoring and in daily once phosphate, daily once potassium, and daily once again. And for sodium and water, I didn't find any proper guideline to pick on. But whatever they are saying is that since because of an insulin-driven sodium and water retention, there will be third spacing for sure. There will be new onset pulmonary edema for sure. So we just have to manage the patient according to what we do in our ICUs for a pulmonary edema patient, new onset pulmonary edema patient. And also one thing I was just going through my mind that when if the patient is on ventilator, we have to be very sure about hyperventilation. We have to put on the ventilator settings in a way so that the patient doesn't go into hyperventilation, because that again, when we'll be talking about hyperventilation, hypophosphatemia loop, hyperventilation is an extremely important part in these patients, so we have to anyhow avoid that. So that's about the ICU management for the electrolytes, I think.
Thank you. So, like you answered very precisely, but I think the audience should go and manage these patients, and you should, go through your doses, because remembering doses in just a webinar is not possible for any one of us. So you have to go and read this about refeeding syndrome, how to develop the electrolyte management. So there are a few questions in the chat box, and I will like to take a few questions, and then we will proceed further. So one, Dr. Shubham Shukla has asked, what is the estimated incidence of refeeding syndrome in mechanically ventilated COPD patients? So any one of you? Okay, Dr.
6 to
Devi.
8%.
Yeah, in mechanically ventilated patient, less than 10%, but as COPD exacerbation, it has been reported as 32 to 40%, especially if the COPD patients are already malnourished, undernourished.
Exactly. So there is, a very literature on these aspects, and to the tune of 30 to 40% patients who are, exacerbation, they develop this syndrome. So then this gentleman is again asking that any risk stratification of refeeding syndrome. So Dr. Shubham, probably we are not to accept this. This is a new entity for us too, and I haven't, till now. So Dr. Devi want to say something, please, Dr. Devi.
According to the ASPEN guideline, there is mild, moderate, severe, and within 5 days of starting your feeding, if the percentage of potassium, phosphate, and magnesium depletes by 10 to 20%, it is mild. 20 to 30%, it is moderate, and more than 30% depletion is severe.
Okay, so excellent, Dr. Devi. So this is update for me also, as I was not aware of this stratification. So now we will come back to our questions, and then in between we will take up some questions from the audience. So now a very important aspect, and going to a very important person. So how do we do the fluid management in such patients? Dr. Mahavir Modi, sir.
Yeah, thank you for the question, Dr. Darshan, because fluid management is something which is very important. In our clinical scenario also, we do get patients, and I stay in a community where, there are a lot of some religious people, those who do prolonged fasting or maybe starvation. So they don't eat for like 15 days, 28 days, maybe only a sip of water in a day. And then they come back to you, and, they get dehydrated, and somebody from the society will call you. And then we will try to know that how much fluid these patients should be taking. So most of the times we have to understand that the fluid management for most of these patients can be oral supplementation. We need IV supplementation only if the patient is in shock, if the patient is in dehydration, okay, severe dehydration, or if the patient is having electrolyte imbalance. And in those category of patients, definitely we have to give IV therapy. Otherwise, many times, if you're getting those kind of patients, what you are staying in nearby to you, and they're doing some religious starvation, so those kind of patients, so their oral fluid supplementation should be good. Around 25 to 30 ml per kg per day is something what is recommended. So maybe for a 50 kg individual, around 1 to 1.5 liters of fluid per day, that is what is required. We have to be very cautious while treating these patients, especially if you're giving intravenous supplementation for these patients, because we should not be overloading these patients. Because what happens is, because of the insulin surge, so these patients, they may develop electrolytemia, what we just discussed, that these patients may have hypokalemia, and plus so you have to be very cautious. Give IV fluid also in such a way that the patient will be only euvolemic. You don't want to hypervolemic. If these patients, they become hypervolemic, then what happens is, many of the times, if you're not giving thiamine also to these patients, then these patients, because of thiamine deficiency and plus because of the excess of IV fluids, these patients, they can get converted to something which is called as wet beriberi. Okay, so then these patients will have high output cardiac failure, and then these patients have very high morbidity mortality because of the excess IV fluid causing wet beriberi and causing pulmonary edema. So we have to be cautious in giving the fluids. Many of the times it is said that if any such kind of patient comes to you, then first thing what you will do is you will like to say that give electrolyte water to these patients or give extra salt to these patients, extra sodium. But extra sodium again is not required for these patients because of the insulin surge. Already these patients, they may develop more and more water retention. So not to have limited salt also, not to have extra salt also, but something which is just to keep a monitoring of your sodium, potassium, phosphates, and accordingly we should be able to manage this kind of fluid management. We should not be giving too much of IV dextrose because as we just discussed that we have to start with maybe around 5 to 10 kilocalories per kg per day. So that is what is required. If you are giving a lot of dextrose, we are giving 25% dextrose, then it becomes a very high calorie intake, and then these patients, they may have hypophosphatemia, and then they may have complications of this. So normal saline is something what is which I will recommend, and not the dextrose or the DNS kind of fluid. Even the ringer lactate also should be okay. But to maintain eumolemia, avoid extra salt and oral supplementation as the first therapy. And if not, then if the patient is a dehydration, hypotension, then give the IV therapy and keep a chart about your daily. Maybe initially you can use even 6 to 8 hourly if the patient is ICU, to have phosphate and sodium, potassium, those kind of electrolyte, magnesium to be monitored, and afterwards then you can do it maybe 12 to 24 hourly. So fluid balance is, I think, which is very crucial. If you have a patient who's very critical, he's in the ICU, and then of course you have to see for the IVC, you have to see for the central line pressure, and then depending upon that also you can manage these patients. But majority of the patients, they may be treated even with the oral supplementation.
So excellent, Dr. Modi sir. So we have to basically monitor the fluid with weight, the output of the urine and
Yeah,
the edema in the patients. And, because fluid overload can lead to many cardiac complications. So it is of utmost importance to monitor this fluid. And
intake output charting is something again, and plus the daily weight of the patient. See for if the patient is developing peripheral edema, any signs of wet beriberi. So
absolutely,
those things also needs to be taken into consideration. Yeah, nice point.
so one of these chat questions I will like to. So Dr. Shubham Shukla again has asked that why potassium, phosphates, and magnesium deplete intracellularly during starvation. So Dr. Shubham, as we were discussing in the panel this presentation, that because of this carbohydrate reloading, there is an increase in the insulin surge, which is leading to the cellular uptake of these electrolytes, which is leading to the decreased serum levels. So basically, this carbohydrate reloading, which is leading to the insulin surge, is a basic culprit behind these electrolyte imbalance in the serum. And then we have to, of course, see the thiamine deficiency also. So these are all are things which we should see for patients who are having this syndrome. Anybody wants to add something? If I think
as there will be a shift from a regular glucose use to a glycogen use,
yes,
the phosphate requirement in the cell and all will come down. So there will be shift from intracellular to the extracellular. So that's why though the serum levels are normal, because the serum levels are normal because there is shift from intracellular to the extracellular space. So our serum levels of phosphorus and potassium in starvation can be normal. So when we start the feed, there will be insulin surge and there will be reversal, that there will be inward shift of the potassium and phosphorus for again glucogenesis. So that's why there will be an acute shortage of this potassium and phosphorus. So because of change in metabolism, there will be a depletion of intracellular phosphorus and potassium.
so this topic has taken us back to our
biochemistry.
MBBS first year days when
the most neglected topic there.
So now, because you neglected that time, so now we are discussing it now. So Dr. Shubham, thank you for that question. Dr. Shubham, like he has been from the Department of Respiratory Medicine of our department itself from KGMU, and he's a very brilliant, young budding pulmonologist, and like he's good at almost everything. So, Dr. Shubham, I hope your answers are being answered. Your questions are being answered, of course. And
I would
please,
also
you
like
also update
to
us.
I'd
Okay.
like to add one point, sir, to what Dr. Shubham asked actually.
Yeah.
So, hello, sir. Am I audible?
Yes, yes.
Yes, yes, you are very much audible.
Sir, basically what happens is when there is a CO2 load, I mean, carbohydrate load, naturally it has a higher respiratory quotient, and naturally the VO2, that's the production of carbon dioxide, increases. So that gives the feedback for a hyperventilation. And this hyperventilation in a very short time, that alkalosis which is formed in a very short span of time, that the intracellular pH को कम कर देता है, and immediately the all the pathways which are ignited in an intracellularly low pH, all of them, if you see, if we go back to our biochemistry days, we'll see that phosphate is being taken as a metabolite anywhere. It's this first phosphofructokinase, glucose 6 phosphate, ribose 6 phosphate. So phosphate is being taken immediately because of this drop in the pH, which again has been caused because of the CO2 the CO2 being more produced and hyperventilation. So that is also one of the most important factor because of which there is a severe shortage of phosphate intracellularly. So that's one point also.
So thankfully, I have four gems with me, four Koinurs who are taking up all these difficult questions and answering you. And Dr. Dewey, of course, I was counting on him also, and he is giving like answers like a veteran. So thank you, Dr. Dewey, for those brilliant inputs. So
Sir.
now, of course, every disease it leads to some complications. So like we have to address to prevent the complications. So now, Dr. Devi, it's your turn. Like, what are the various complications associated with refeeding syndrome?
So refeeding syndrome can affect all the major organs of our body. So like if it affects the heart, there can be arrhythmias, there can be acute congestive cardiac failure. As we have already discussed, it can affect our lungs and cause muscle weakness, especially diaphragmatic muscle weakness, leading to increased CO2 and also pulmonary edema. It can cause neurological problems like due to the deficiency of thiamine, it can cause magnetic encephalopathy, it can cause seizures, coma. Due to the muscle impact, it can cause rhabdomyolysis and it can also cause mortality.
So you see, like this refeeding syndrome is so disastrous. If it is not addressed properly, it is leading so many complications and even to the death of the patients. So like addressing it at the right time is the we know that this is predictable and preventable also. So we have to try. Prevention is the most necessary step. We have to prevent refeeding syndrome to avoid all the complications. So this is the prevention is the best strategy. So like from ages back, we know that we should prevent. Prevention is better than cure. So we should try to prevent, and of course, if it develops anyhow, then we have to try to reverse it. So thank you, Dr. Devi. And so now, of course, it is can be, you can say, we ignore some things. So that is why we lead to some, development of some kind of negative things like refeeding syndrome. So now, Dr. Bhima, can you just enlighten us about the various pitfalls which leads to development of refeeding syndrome in high-risk patients?
Yeah. As you nicely mentioned in your slides, the core principles of treatment. What are all the core principles? If you neglect it, they are all the pitfalls of our treatment, right? So let me share a quick some cases there. Okay. So think of an elderly obese person who has been on diet for past 1 month. So if he is also having a COPD and carpal right? He has been into ICU for acute exacerbation. He has been intubated. He has been on deep sedation for 1 day, and the next day we have planned for starting the rice feeding. Okay, we have started rice feeding with low calorie intake, low calorie supplementation itself, but still the second day after starting this, he has developed raised CO2 levels and tachypnea, even on ventilator. Okay, So that's when I thought of this refeeding syndrome. So even after following the low calorie diet, he has developed refeeding syndrome. So what are we missing here? The first thing is the pitfalls here are improper history taking. Okay, so we have seen him as an obese person with good muscle fat. He is doing well. Okay, but his history, he has been on diet. He has been under nutrition for 1 month. So that's keeps him at high risk. Okay, as per your Aspen, it's in high risk. Okay, so next thing is COPD, pulmonary, improper risk stratification. Those who are having significant disease, they come under high risk for refeeding syndrome. So improper risk stratification. And next one is inadequate monitoring. Okay, here we have missed his serum phosphorus levels. We have not done it. So improper monitoring, regular monitoring is needed, even if, as you mentioned earlier, even if your serum initial electrolyte levels are normal. Okay, this is the most important pitfall. And next thing is missing thiamine supplementations. So we usually give thiamine and all for chronic alcoholics or withdrawal syndrome and all, but we usually miss it for in our COPD cases or in our regular cardiac cases and all. Okay, so good history followed by stepwise proper management avoids all these pitfalls. And next important thing is management of fluid balance. Say this case here it is COPD with pulmonary who is having high risk for cardiac decompensation. So we have started on electrolyte supplementation where the insulin surge takes up creates a sodium retention and water retention. So that will lead to pulmonary edema. So these are all various pitfalls. So if I need to enlist it, proper history taking, proper risk stratification, electrolyte estimation before starting, and low calorie intake, low calorie supplementation, and regular monitoring. So these are the must for treatment of refeeding syndrome. Yeah.
So thank you, Dr. Bima, for your wonderful answer. So what I think is the most important is the ignoring the nutritional history of a patient.
Yes.
So we very casually take nutritional history.
We usually don't take it.
We don't take it. We don't consider it. So it becomes very important. And this entity highlights that what is the importance of nutritional history. So it's for the physicians who are like practicing, who are like beginners kind of, and we have just like in their training also. So it's my request, earnest request to them, please take proper nutritional history, like descriptive nutritional history from those patients. And it really very helpful in guiding the management of such kind of patients. So thank you, Dr. Bima. And so I am very proud and glad to announce that today, despite of this semi-final of India and England, and even I am like looking at my watch again and again, let us finish this and I will watch the match after that. So, but the funda of CCI is the show must go on, So when Dr. Atri contacted me for this webinar, and he didn't told me that today was the match. So like he played, very safely. And because of the Holi, because, I am fond of playing Holi. So I requested Dr. Atri to give me a easygoing topic, because it is a topic which is entirely new to me also and many of us. So, but, there is hunger for learning. Today we can see that we had more than 2,200 logins today. And probably like it is equally like, for the other CCI webinars, like it is a equal logins. मतलब I want to say कि जितने बाकी logins होते हैं उतने हमारे webinar में भी हैं. तो thank you audience for logging in, and thank you for listening to us. And you are like we are trying to remove your holy hangover, and like we have of course we want to see the match also. And so thank you. I am overwhelmed. So this is a like great experience today. So, and this is because, this is a topic which we were not very aware of. So this is an out of box topic which everyone wants to hear. What is refeeding syndrome, and what is refeeding syndrome association with the lungs? Because so today, we have gone a bit wiser. What is refeeding syndrome? And so now it's time to delve in more for this management of this thing. So now we will see cases in our IPDs and the ICUs also, and we will try to address this entity. So now, Dr. Devai, so this question goes to you. So can you just let us know what are hidden clues of presentation of this syndrome in a COPD patients?
Again, a very relevant question, sir, in our practice. So basically, if we want to see when our patient is landing on refeeding syndrome, we need to know who of our patients are at risk. So for understanding that, as Dr. Devi has already explained so many times, that Aspen and NICE both has an immediate and very well written criteria for to understand who are of our patients are at risk. So we have to keep that thing in our mind before we try to make a hunch that if it is refeeding syndrome or not. So with that in mind, we start, suppose now after that we have started the feeding on the of the patient, we have to look towards the electrolytes. Even if there is a less than 5% drop in the basic electrolytes like phosphate, magnesium and potassium, we will think of refeeding syndrome. This comes from laboratory test. Now on clinical hunch. For clinical hunch, as we know that it's because of a carbohydrate load. So naturally, as I was talking a few minutes back, it has a mode of respiratory quotient, and naturally amount of carbon dioxide will be higher in our blood. So there will be a new onset or a fresh increase and hypercapnia, increase in CO2 in the blood. So that may give us a hint that probably our patient is landing onto refeeding syndrome. That is point number one. Point number two would be because hypophosphatemia, we have learned that is the hallmark of refeeding syndrome. So with hypophosphatemia, there will be less ATP, less 2,3-DPG, and naturally there will be a shift of the hemoglobin curve towards the left. So unloading of oxygen will be less to all the tissues. So our muscles and all the tissues will be in a hypoxic state, and naturally for that, our muscle weakness, diaphragmatic weakness, and the strengthens and all the muscle efforts will be less. So I will see the patient, if the patient is not in ventilator, I will see the patient feeling a breathless, but still its PO2 or PO2 is normal. If the patient is in ventilator, we will be having the patient's effort more. If we are keeping down the trigger, the patient will be having more effort to generate the tidal volume. If we are on SBT, suppose we are doing a spontaneous breathing trial, we will be having failure with an unexplained answer. Why the patient we are failing on the SBT? Number three is sodium and water retention. So that will be again causing newer onset crackles on auscultation, newer findings on the chest X-ray, and then again an unexplained and new onset pulmonary edema. So these three are the hallmarks and the more important things. Apart from that, there will definitely be signs of low potassium, signs of low magnesium in form of tachycardia, arrhythmia, new onset dementia, psychosis, and all of that. So these mostly, I think, can be a summary of when we can actually hunch that the patient is landing onto a refeeding syndrome.
Yes, Dr. Devai perfectly said. So just adding a few points to this, that a patient of COPD who is having sarcopenia or patient is chronically hypoxic. So these patients are also prone to develop, if you are dealing with a case of COPD patients who are malnourished, who are having sarcopenia, having chronic hypoxia, these patients are also prone to develop this refeeding syndrome. So when it comes to pulmonology perspective, and of course, COPD is one of the most important case we deal with in our day-to-day lives. So thank you for that. So now, this question goes to Dr. Mahavir Modi, sir. What are the effects on lung function in a critically ill patients with refeeding syndrome?
Yeah, I think a discussion in Pulmonology forum won't go without a PFT answer, PFT question.
Absolutely, absolutely.
Otherwise, I don't think it's a very relevant to, do a PFT for a patient who's having a refeeding syndrome. But of course, because as we all have discussed that these patients, basically the hallmark of the diagnosis is the hypophosphatemia. And as I said in my initial answer, that the phosphates are required basically for the ATP synthesis. So because of low ATP, these patients will have diaphragmatic muscle weakness. And because of diaphragmatic muscle weakness, of course, they will have low tidal volume. There will be poor cough reflex. So they will have a restrictive kind of the pattern on the lung functions. Plus, because of this poor cough reflex, and again, as I said, many of the times these patients, they may be loaded with the fluids because of which they develop pulmonary edema. Again, because of pulmonary edema, there will be low tidal volumes. And hypophosphatemia combined with again your hypokalemia, hypomagnesemia. So all of these, they will again cause basically diaphragmatic weakness, and especially if these patients in sleep, because in sleep we know that during REM sleep diaphragm is the only active muscle. So because of this, these patients they will have more and more shallow breathing at night, because of which there can be hypercapnia. So these patients will start developing or retaining CO2, and especially if you have patients like a COPD, those who already have a poor respiratory reserve, they already have high CO2. So these patients, they can land up in bad respiratory crisis, respiratory failure, and then they may get intubated because of this. So I think one of the major reasons is because of this phosphate. But sometimes if you're not giving thiamine supplement, then these patients, they may develop even lactic acidosis. So because of lactic acidosis, these patients, they will have a very rapid shallow breathing because of the acidosis. So all these are, I think, in nutshell, are the respiratory physiological parameters of the lung function worsening, what we can expect in these patients. So just to highlight, I mean, phosphate supplement is something which is very important for these patients, especially if they are on ventilator and you're not able to wean these patients. Sometimes even patients with NIV also, if they have low phosphate levels, and it will be difficult for us to wean, because phosphates are very important for the diaphragm function, and phosphate supplements are not readily available. So during our, around 20 years back, 22 years back, when I used to work as ICU consultant, so there we used to give phosphate supplements as, all this proctolysis enema. So this proctolysis enema, which is sodium phosphate, and it is very rich in phosphate. So instead of giving the proctolysis enema through the, we used to give the proctolysis enema through the, not enema, but the proctolysis powder. We used to give it through the Riles tube. So for the patient, those are mechanically ventilated. So for these patients of phosphate supplement, we used to give this proctolysis through the, even dietary supplements. So these patients, we used to call them to give radish juice. Okay, so radish juice, and sometimes even the corn soup, the lentils, the corn soup. So all these are dietary supplements which I think you can tell your COPD patients, and especially if a patient who is critical and not coming out of ventilator, you are supplementing with trace elements. But phosphate supplements are not very readily available nowadays. We get phosphate powders also, they're available, but a few years back they were not available. And dietary supplements are something which are very, very important, and patients can definitely, the relatives can bring it and give it to the patients. So radish juice can definitely work as a phosphate supplement, and this your proctolysis enema giving through Riles tube, that also can work as a phosphate supplement. So thank you.
Thank you, sir. So basically, simplifying it, effects on lung function, that you have a diaphragmatic weakness, so there is a reduced vital capacity, and there are impaired cough reflex in these kind of patients. And these patients are more prone to develop atelectasis, pneumonia, or even ARDS. So we have to assess the lung functions appropriately, and we have to try to prevent all these. So this even cough reflex gives a sign of that you have an impaired lung function. So now moving on further. Dr. Devi, so which categories of pulmonary patients are at risk to develop this syndrome?
So as we have already discussed the high risk population in general, now coming to pulmonary patients, so the risks are more or less similar.
Coming to our domain, yes.
Whoever are undernourished or decreased intake or involuntary weight loss. So like COPD patients who are undernourished, ILD patients who are undernourished, COPD, ILD patients, or bronchiectasis patients who are chronically hypoxic, like on LTOT, or patients who are in prolonged mechanical ventilation, maybe IMV or NIV, lung cancer patient with cachexia, or patients who are in ICU for prolonged period. All these are high-risk pulmonary patients for refeeding syndrome.
So basically, patient who is having undernourished, like BMI is somewhere below 18.5, or patients of ILD, patients, you told about the post-sepsis patients in the ICU patient who develop sepsis. So these patients are, they are at risk for this syndrome. So that brings to our next question. And Dr. Bhima, you are the person for answering this next question. So what should be a pulmonologist approach for safe refeeding. So we discuss about refeeding generally, but now we are talking in respect to pulmonology. So please just give us a precise answer that how should we.
All the general principles of refeeding strategy applies to the pulmonary cases. Only one thing is all our especially chronic respiratory disease cases, as madam emphasized on it, they all come under very high risk
Just for the
of
sake of
refeeding syndrome.
audience, just can you enlist the general things also for the like refeeding,
Yeah.
so that we can have a revision for that also.
So in refeeding, we will just for providing this calorie supplementation, as far as refeeding syndrome is concerned, we stratify into low risk, high risk, and very high risk. All our chronic respiratory conditions come under very high risk group. So for calorie supplementation, for low risk, usually for those without any risk, we start with 25 to 30 kilocalories per day. For low risk, we start with 15 to 20, moderate risk 10 to 15, and for very high risk, we will start with 5 to 10 kilocalories per day. Okay, so for especially as madam said, COPD cachexic patients or lung cancer cachexic patients or those who are on prolonged ventilator. So these come under very high risk, and we will start with very low caloric supplementation, that is 5 to 10 kilocalories per day. Why? Because as Dr. Doipan emphasized on it, this carbohydrate food is having high respiratory quotient, so they are more prone for hypercapnia. So there is more chance of weaning failure. So we need to start with hypocaloric diet. Apart from that, the electrolytes monitoring, everything holds good for all the cases. And next thing is, these respiratory cases are all more prone for fluid imbalances and sudden cardiac distress, that is arrhythmias or pulmonary edema. So we must be very vigilant on fluid supplementation. Say for example, like we should be calculating each and every calorie we are giving. Say for example, you are giving propofol for sedation. We usually give propofol, right, for maintaining sedation. So propofol is a lipid emulsion. Say the lipid will give 1 kilocalorie for 1 ml. So for maintaining a 24 hours of sedation, we are giving around 800 ml of propofol. So we are giving 800 kilocalories of propofol per day through propofol. So we should take this also into account. So we usually assess what we are giving through rice tube or what we are giving early through our parenteral nutrition. But everything, for example, antibiotics we give through dextrose, that will also add to our calorie intake. So we should calculate each and every calorie intake that is being given to the patient. So for respiratory cases, we need to maintain hypocaloric diet. So we will give it 5 to 10 kilocalories. We will start at 5 to 10 kilocalories, assess his CO2 levels, and slowly, gradually increase the supplementation. Right?
Yes, excellent.
Yeah.
So one point which I want to highlight, that if you are dealing with a COPD patient, despite treating with that patient adequately, optimum ventilation also, but then also this patient is having worsening hypercapnia despite of treatment. So this is a hidden clue that there is can be a refeeding syndrome. So this is a point which I wanted to highlight. So
and always we should maintain the standard protocols, because we need not aggressively try for hyperventilating the case to get to the normal CO2. That is something called permissive hypercapnia. So others ventilator strategies also we should follow.
So now we have finished our questions, which I for the panel discussion I formulated. So just a few important things I wanted to say, like the sources of potassium, magnesium, and thiamine. So you see potassium, like I'm very fond of mangoes and bananas. So thankfully, they are the source of potassium. And apricots, this was a new thing to me, that apricots are also a resource of potassium.
Coconut water.
Potassium.
Yeah.
Coconut water.
Tap water, yeah.
Oh, of course, we know many things, but these things I found like interesting, that even mangoes and apricots, like these are not tempting things, like, like mouth-watering things like mango, and so that is why I wanted to mention these things. Then magnesium. No, now what is the trend? Avocado. Avocado is a trend. So avocado is a rich source of magnesium. So avocado, of course, toast, like these are the latest trend. So magnesium is, is in avocado in abundance. And thiamine, the pork or the whole grains, legumes, and the various mixed seeds, are mixed seeds. Like people are taking the sunflower seeds, the chia seeds, the flax seeds, the pumpkin seeds. So all these are the source of thiamine. So like these are like we can take in our daily day-to-day lives also, like for our like for health, good health. So we can consume these things also. So just this is a bit of interesting thing apart from this our panel discussion. So now like if audience or like can have some questions from the audience.
I think, sir, you have given a very good topic for Dr. Ratri, diet and pulmonary diseases. Because the most regular question, frequent question, what we hear from our patients is what we have to eat. And I will usually say eat everything, no problem in lung.
Yes, that is,
So now you have opened a good channel for Dr. Ratri.
Dr. Atri, are you listening? So over to organizers now.
Thank you very much.
Thank you, everyone.